Hi, everyone. I'm Dr. Margaret Cox coming to you from the great city of Salt Lake City, Utah.
Very nice. And I am Dr. Kylie Moss coming to you from Baltimore, Maryland.
Love Baltimore. Love Baltimore.
But I am only here probably for a fleeting little bit of time. I think we're going to move down to DC where I practice gynecology. And welcome to episode 3. We got a couple of listeners for each of
It's
our.
good. Episode 3 of Vulva Talk coming hot at you
Yeah.
with
With
the
nowhere to go
keeping
but in terms of.
keeping the momentum up. Yeah, the update I think was like 79 cumulative listens. I think that's pretty good. Okay, it's fine. As long as one person listens, whoever you are out there, we really appreciate it.
We really appreciate it. Well, we're going to be kind of, I would say, a departure from our title today and focus a little bit more on vaginal stuff at the outset, because I think one of the hot topics in gynecology that has come up in the last couple of weeks is this article in the New England Journal of Medicine that came out March 6th called Male Partner Treatment to Prevent Recurrence of Bacterial Vaginosis. So this is a trial that I think a lot of our patients are really interested in. I know as clinicians, we've been talking a ton about it. And basically what they did in this trial was they took a group of patients who had bacterial vaginosis and they proved that they had bacterial vaginosis by using something called Amsel's criteria, but then they also gave them a Nugent score. So not only did they use these criteria of what their discharge looked like, what their symptoms were, and if they had an odor, so that means if you add like a chemical to the discharge, if it makes this kind of unpleasant odor. And then they looked under the microscope. Now, normally it's enough to just look under the microscope and say, oh, there are a lot of bacteria that are sticking to the cells from the vagina. But they went actually a step further and did a Nugent score. They stained the cells with a special stain and looked at how did the bacteria look, what was the shape of the bacteria, and they gave a score for that as well. So they were certain these people had bacterial vaginosis. And then they said, okay, if you have bacterial vaginosis and you have a partner that you've had a long-term male partner, or at least a male partner for the last 8 weeks, we want to see if we treat you and the partner, if that's better than treating just you. So is it better to treat male partners and people who have bacterial vaginosis? And the results were really interesting. They definitely had a reduction in recurrence. So it wasn't perfect and it didn't completely eliminate recurrence. But it did reduce it. I think it was like 35% recurrence for the folks who had their partners treated, and it was much higher for the folks who didn't have their partners treated. Where is it like
3%. So in their treatment, in their male treatment group, they had 69 patients and only 24 of those patients had recurrence. And in the non-male treatment group, they had 68 patients and 43 of those 68 patients had recurrence within that 12-week period. Where has this study been for the past like 50 years? I feel like I feel like we talk about this every time. As a vulvar dermatologist, I see a little bit of bacterial vaginosis. I mean, I do wet preps in my clinic, and I also do vaginitis panel testing. And this is always kind of in my mind when patients are coming in with any kind of vulvovaginal symptoms. The teaching has always been like treatment of the male partner doesn't make a difference. And now there's this like mind-blowing new information. And is it even new? Because I feel like they have done these studies in the past, but maybe the main difference here is they were doing the oral metronidazole and the topical clindamycin for the male partner. That was one of the main differences for me.
Yeah, I think that the studies that came before, and they talk about this in the paper, had such significant limitations, be they sample size or methodology. I think it's also interesting in this trial, come on, guys, the men still had a hard time adhering to the regimen. The women did too. The patients with vulvas had a hard time too, but the male patients reported that they did have some percentage of I saw 8 of the 56 reported taking less than 70% of the doses prescribed of the medication. So you got to wonder, like, if this result would have been better if they were more adherent to the regimen.
Totally.
So it's one thing, like the magnitude of the result could have been greater. I think it's going to be really interesting how this changes practice. I mean, it's hard. It's, things that cross over to the male partner. The only analogous thing I can think of in gynecology is like semen analysis for patients who are experiencing infertility. And it's always this tricky dance of like, okay, I'm an OBGYN. I'm technically have a hard time for patients who are, have been assigned male sex to prescribe something for them, like a semen analysis, even though it's clearly within the scope of the problem. And so I don't know how it's going to work to prescribe for men. And the other thing is that we have expedited partner treatment for sexually transmitted infections, and we do prescribe for men, but the laws vary state to state whether that is within the purview of an OBGYN. And you really have to figure out if you're allowed to prescribe for men. So actually, maybe someone like you who has a board certification where male treatment is included, it might actually be easier. It's going to be easier for the internal medicine person who maybe is the.
I mean, I haven't had any kind of like BV since this paper came out. I mean, it's only been a couple of weeks, but I definitely have a couple of patients where I think I will absolutely take a stab at treating the male partner to see if this can be adequately treated. Do you ever treat a male partner in a patient who's having candida, like vulvovaginal candida? Have you ever done that?
No, I haven't, because I also think that the data isn't there. Recommending that treatment. But I will say, like, I have heard anecdotal stories where like the patient kept getting candida. Male partner like mentioned it to their physician, and they ended up getting a new diagnosis of elevated blood sugar, prediabetes, or diabetes. So that is the one thing I'll say is like, it's anecdotal. I don't have a randomized control trial. But, one of the risk factors for more yeast growth in anyone is an elevated blood sugar, right? We know our diabetic patients, they have a lot of trouble with yeast on their skin. I'm sure you see that all the time. And so I do think that can sometimes affect a partner with a vulva. And so sometimes I will say, like, listen, does your partner, like, are they in good health? Have they had their health screening? It might be worth getting an A1C, which is a blood test that can measure their average blood sugar over the 3 months before the test. And if it's high and they get treated, then maybe their blood sugar comes down, they will be less prone to having a high yeast burden on their skin. I tell patients, like, yeast is on and in us. You're never going to completely eliminate the risk of yeast transmission, but maybe you can reduce it.
Yeah. I mean, there have been a couple of instances where I have had patients who have kind of recurrent yeast and have attempted that of treating the male partner. I wonder if that's a next study in the works.
Because I'm sure there are methodologic flaws in the studies we've done.
Yeah. And I find, what I found very interesting also was that there was the relationship between that BV recurrence if the male partner is not circumcised.
Right.
Did not know that, but there it was. And I was like, oh, maybe the next study will be like, if you circumcise the partner, will that eliminate the BV? Yeah. But I guess they didn't really find an association with that because they also talk about IUDs in this. But what I love about these kinds of papers is this worked so well that they had to stop the trial in the middle of it because the results were so much in favor of treating the male partner. I mean, this is like,
I know. I really do want to see what it's like long term, and I hope they're going to follow the folks that the partner got treated. Because one of the things I worry about with a study like this is like, if we all lived in a bubble with no bacteria and were sterilized, like we wouldn't develop bacterial infections, right? But so is this a temporary stay, right? It's not practical to have both parties on antibiotics all the time necessarily. And so it's going to be a tricky long-term proposition.
Were they doing a long-term thing of this? I don't remember reading that.
They are. This is only 12 weeks. So, it's just, I just wonder about the sustainability of this. That's the thing. It's like, I hope that it bears out. So I guess long-term studies we need, but it does seem like in the short term that this really may help.
Perfect. Yeah.
The other thing I will say is they mentioned the one other study, which showed that live vaginal probiotic for like 11 weeks is the other thing that is shown to reduce recurrence. And I think that has some promise too. And I know that there's an ongoing trial with that in the next year or two. Hopefully we'll hear the results of another like vaginal microbiome transplant type trial to reduce recurrent bacterial vaginosis. So more to come on this for sure.
What is that? Is that a probiotic that's available or?
No, it's not. It's a composite probiotic. I don't know how many microbial strains are in it, and I'm guessing it's proprietary. But
Okay.
I know that the person who's working on it is Jacques Ravel, a University
Yeah,
of
I see him.
Vaginitis person.
I
Because
see
he
him
talks
on
about it
here.
in Sesame D actually.
Yeah, no, I remember him. So do you recommend probiotics to patients who are having recurrent BV?
I don't generally because one of the points that he made was that you really need to have a whole community of microbe in the microbiome to support good probiotic bacteria. So, like if you have Lactobacillus crispinus, which is the one that's like been cited as associated with a healthier vaginal microbiome, the problem is Lactobacillus crispinus needs a number of other bacteria to support it. And if you just put Lactobacillus in the vagina, then it won't stick around. So you need this whole other community of bacteria to help. So that's why it makes sense that like a sort of a frozen probiotic with live cultures that have many, many strains makes a lot of sense. And it has to be vaginal. There's no data that any oral probiotic
Oral.
is the vagina. So
Yeah, no. Well, that's it's coming up, I guess, the
yeah,
future.
fingers crossed.
Hopefully sooner rather than later.
Yeah. Yeah.
So basically, you're saying don't buy any supplements you take by any probiotics you take by mouth.
Yeah. Cool.
This is like,
Facts.
yeah,
I mean, take them for their gut. Like, I guess talk to your gastroenterologist about that. And we should say none of the things that we say here constitute medical advice.
That's true. That was supposed to be at the beginning.
Well, better late than never. So, but yeah, I think I don't recommend oral probiotics. Like, if you're going to take something with Lactobacillus crispinus, it's probably not harmful vaginally. I just don't know that it offers a sustainable change in the microbiome, which is what you really need to prevent these things.
Yeah.
Yeah. Yeah.
Great.
All right. Well, should we move on to another article? So we're kind of doing two articles because that one was more like pop culture buzzy. And
totally.
and then this article, I think, is an important article and full disclosure written by people that I know pretty well.
Mm-hmm.
And this is the phase 2 randomized study of abobotulinum toxin A with provoked vestibulodynia, dose finding results. And this is by my senior partner, Dr. Andrew Goldstein. Rachel Rubin's on the paper. Erwin Goldstein's on the paper. Jill Kraft is on the paper. These are all people who participated in the trial and helped sort of sculpt the product of the paper that came out of the trial. And so this is obobotulinum toxin A is one of the brands of botulinum neurotoxin. Most people know the brand Botox, but there are lots of different brands of botulinum neurotoxin. Botox is kind of like Coca-Cola. It's a brand name like Pepsi or Coke. And so there's different kinds. There's abobotulinum toxin. I was looking into this because I wanted to know a little bit more about the different types. I think it's like parabotulinum toxin, and then there's onobotulinum, which is Botox. For derm stuff, what do you guys use?
So primarily we use kind of either the ONA botulinum toxin or the abo botulinum toxin. So Botox and Dysport. Okay. Those are the primary ones that we use, or the ones that I probably have the most experience with. And then there's some other ones and some newer ones that have come up, but those are the two most common ones that are used kind of like for cosmetics. So again, for the glabellar lines, so those are the lines between your eyebrows, or for like forehead lines, or like lateral canthal lines, the crow's feet lines. And then we use them for other things in dermatology as well. We use the Botox or Dysport for severe sweating or hyperhidrosis.
Yeah, I was actually, I gave a talk on vulvar dermatoses at like a grand rounds on Friday. And I was talking about how there is a trial for Haley and, or like because that's a problem related to sweating. So it's like, oh, it's weird. It could be treated for use for that.
So you can inject Haley disease, but we'll do like armpit sweating or like palmar sweating. So you can inject Botox directly into the hands, or scalp, like if people have really bad scalp sweating, or even groin sweating. That's a pretty good treatment if you fail other things. And I think that's mostly it in dermatology. And then I think there's people use it for migraines. People use it for pain in other parts of the body. One of the ones that I think now is up and coming is, I have never done this myself, but it can be used for post-herpetic neuralgia. So the pain that you get in a dermatomal distribution that comes when you have like a shingles outbreak. Apparently,
Yeah.
there's some studies that show that it can be pretty helpful for that.
Yeah.
So it's like it's the miracle toxin, it does so much.
Well, interesting because we have patients who have like a post-herpetic neuralgia and they develop pelvic floor muscle dysfunction. So
Uh-huh.
for them to like it may help with both issues, basically. Yeah.
Yeah, yeah. So, and I think that we classically think about Botox as just having an impact on neurotransmission and causing muscles to not contract or work, but I think it does a lot more than that, especially in the reign of pain and potentially even itch. And so I feel like even in the setting of this paper that we're discussing, it probably has multiple mechanisms to help with vestibulodynia, not only relaxing the pelvic floor muscles, but also having local effects on how nerves interpret pain.
Yeah. And so what they did in a trial is they injected at 5 different sites, the bulbospongiosus, the transverse perineum, which is the muscle
Mhm.
between the vulva and the anus, and then these 2 muscles on the sides, the pubococcygeus muscles that are a little bit deeper than the bulbospongiosus. And those make sort of like you can think of it as a saddle sort of shape, or a shape like Andrew Goldstein always talks about, like an old fashioned swing with 2 chains and a leather seat. And so they injected sort of in a round area, and they did it. There was a placebo arm and then there was a dose escalation. So they tried it at several different doses. And unfortunately, one of the tough things about this trial is it got interrupted by the COVID pandemic. So they didn't get the complete.
Yeah,
And, and
that's
so,
annoying.
yeah.
COVID.
Yeah. And so some of the patients that had enrolled didn't get to complete the protocol. It was just
Right.
tough because I think at the time they didn't know if people could come in safely to the office at all.
Yeah.
So that's a little bit of a bummer, but it sounds like they were still able to get a good assessment of things like adverse events. Um, and I guess when you're talking about Botox on the face, you probably see problems related to overuse, right? Or excessive use. I'm wondering.
Yeah, so you can definitely get the Botox to affect muscles that you don't want it to affect. And on the face, most classically, what you'll see is someone will drop an eyebrow, so you literally cannot open your eyelid because the muscle is not working, and that is kind of annoying. I mean, it goes away over weeks to months, and there's certain eye drops that we sometimes give patients that can kind of accelerate that process a little quicker. But basically, you just have a droopy eyelid until the effect wears off, and usually that's kind of 3 to 6 months, depending on how you react to it. But we don't really see a lot of adverse effects beyond that. I mean, you can get some bruising, you can hit a vessel and cause like a bruise, a pretty obvious bruise, and maybe some irritation. I mean, it's painful sometimes. The injection itself can be uncomfortable.
Yeah. Yeah. And so here, when you're talking about injections that are in the muscles around the vulva and the vaginal entrance, you're very close, especially if you're injecting the transverse perineum to the anal sphincter. And so you can get leakage of gas, or you can get incontinence of stool,
Yeah.
or you can get urinary incontinence if you're probably a little bit higher up near the bladder. I haven't seen that in our patients. We tend to have patients that have a lot of hypertonicity, and so I think when we're injecting, knock on wood, had very good luck that it doesn't tend to affect them adversely. But I always talk to patients about that potential.
Yeah. Yeah. So in this paper, it seems like they only really reported like 4 instances of that total, 3 of that urinary incontinence and 1 of that anal sphincter atonia, which
Yeah.
seems not that bad.
No, not that bad. And I would say that is in line with my own experience. I mean, we just have
Yeah.
little in the way of adverse events. I think in the last few years in our practice, we've had a couple of people at risk reports of leakage of gas, but it's usually pretty temporary and not even like the full duration of the medication, usually, weeks to, month or 2. And, one of the things I really liked about this trial is their instrument that they use to measure efficacy, and that dilator test, because that hasn't right before. We've had the tampon test, which is where you just
Right.
like insert a tampon and see and report, and that's very binary. It's black and white, like you have pain with the test or you don't. And this is more graduated. They used a standardized set of gradual dilators and had patients report their pain with each of the dilators and then stop when they felt like they couldn't tolerate it. And whatever number they got to, the numbers above that, they got a score of 10, basically being max pain because they couldn't tolerate those dilators. And then they added up the scores to try to figure out what people's totals were like. And they did have reduction in scores over the course of the trial. That reduction was the most in the patients that got I think 300 units. But it's hard because the placebo part was very early on and then it became open label. And so the difference relative to placebo is pretty modest and I don't think statistically significant, but it's a hard trial to design to figure out on this big wide range of doses, what is the right dose for people.
Yeah, my take on this was that they were mostly looking to see what the adverse events were. Is that right? Because I feel like the dose thing, it seems like there was no dose response was observed.
Right. There wasn't a curve
among the dose. Yeah. So it didn't matter if you got 100 units or 400 units. There wasn't really a dose response.
Right.
And then for the where they were testing the doses, there was no placebo.
Right. So it's tricky. It's a very complicated.
And then COVID happened.
Yeah, and then COVID happened. But I think
this is a real tour de force. I mean, there's so much data in this. It's a very rich paper.
Yeah.
We talked about this, Kylie, you and I, about me coming over to you to learn how to do Botox.
Yes, come on over.
I don't do these in my clinic, so I have done it just on the external kind of cutaneous vulva, and there's a couple of papers, case reports of that working. So I have tried that with probably limited success.
And the good news is you're probably still getting a little bit of bulbospongiosis there. And you're going between the vulva and the anus, you're probably getting a little transverse perineum. I mean, when we inject, we usually one of the injections is straight into the perineum, sort of perpendicular. There. So you probably are getting some of the same coverage. We just tend to do some more getting the pubococcygeus because I do think that, one of the reasons that people have pain is the insertion points of the muscles are right in the vestibule, but then another reason is just the physical contraction. I mean, so I think you can get efficacy even with probably some superficial injections, but our technique tends to cover both sort of the superficial and the slightly deeper sort of middle layer there with the pubococcygeus. Yeah.
So are they planning on restarting this or doing more?
I think they will really want to keep going and go for FDA approval, but I don't know about the industry talks that would go on with that because obviously it's a trial that was sponsored by Dysport, the makers of abobotulinum toxin A. And so I don't know what their plans are in terms of continuing with phase 3 or kind of going forward with FDA approval. I would really like to see FDA approval of a botulinum neurotoxin. I think for us, it works really well and it would help with broader access to the drug.
Yeah, because I feel like that's the limiting thing here. It's completely out of pocket.
Right.
To have this done because no insurance is going to cover this.
Yeah, and it's hard because it's one of those things that when I do it, I feel so good about it because it's usually really helpful to patients in my anecdotal experience, but it is not in reach for a lot of patients. And honestly, I'm in a privileged position where I see a lot of patients that have significant resources, and we just need to broaden access for sure. Yep. So yeah, I guess I'm hoping things will keep going with another trial.
That would be great. Yeah. And then I got to figure out a time when I'm going to come out and hang with you and be more.
I wish we had planned, cherry blossoms are happening in the next few weeks. Could have gotten on the cherry.
Yeah.
And a little bit of Botox.
I lived in Baltimore for 4 years, so I went to DC for the cherry blossoms, but I feel like every year they're kind of earlier and earlier, right? So now are they coming now? I guess it's kind of late March, so.
Yeah. But I don't think it's going to be peak. I think it's the last weekend of March. So yeah, next weekend.
Yeah. Too bad. I just got to figure out my clinic sitch, which might be a problematic thing.
Oh. Well, I'm here. When you want to come.
Speaking of clinic.
Yeah.
I have kind of moving on to more of the patient question area. One of the questions I've been getting recently is about breast implant illness and lichen sclerosus. So I've had a few patients who have been wondering if maybe getting a breast implant at some point contributed to worsened, etc., the development of vulvar lichen sclerosis. Now, I kind of have heard about breast implant illness before. So when I was a path resident, we would look at breast explants, and there was a risk of developing a lymphoma kind of around the capsule of the
Yes.
breast. So that was one of these breast implant related illnesses. And other than that, I didn't have a lot of familiarity with it, although there was a growing literature in the 1990s, not the 80s, that there was this autoimmune reactivation that happened with breast implants. And a lot of that was, they did some studies and I think they debunked a lot of that, but it's coming back now. And I feel like we still don't really know the answer to this. Have you gotten any questions about this?
I haven't. It's something that I had a patient who had wanted to get her implants out just because they were a certain, it had been a certain amount of time since she had gotten them in. And she, there's some special breast imaging that you have to do. And she was, I think, more tired of like the maintenance, but but that was not a patient that had lichen sclerosis. So I haven't had that question a lot. I haven't.
Yeah. So when I had this patient, a question from one of my patients, I was like, okay, let's do a little lit search and
Yes.
see if there's anything out there. And the only thing that I could find with respect to specifically lichen sclerosis was that there was a case report that was published in 2022. That was the only one I could find, but there may be more, where it was a case of extragenital lichen sclerosis that happened on the breast in the setting of silicone breast implants. So extragenital lichen sclerosis is lichen sclerosis that happens away from the genitals, so not on the penis or the vulva. And it typically looks very similar. So it's this kind of depigmented atrophic plaque that can have some peripheral erythema, maybe a little itchy. Anyway, it usually happens in about 20%, up to 20% of patients who have vulvar lichen sclerosis. Yeah. But in this lady, she was a young lady, she was 29, and she got this kind of white plaque on her breast. I mean, was it related to the breast implant itself? It's so hard to say.
It's just so hard because,
so hard.
People have that without getting breast implants. And when we only have one case study, it's really...
And, the larger cases, reviews, et cetera, that have looked at breast implant illness and autoimmune disease, they have not found like 100% correlation, but there's sort of increasing evidence that shows people who have their breast implants removed seem to have less symptoms of their autoimmune disease.
Right.
But again, it's so hard to kind of directly correlate those two.
Right. You would have to, the best way to do that study is to, follow people who got implants and follow people who didn't for their, almost like,
right, exactly.
Because it's not like you could randomize people to implants, but you could do maybe a case control study prospectively to see, but it would need to be decades. And that's the thing about these rare outcomes.
Absolutely. I mean, I think, and then even in first place I always go to for any information is UpToDate. And even in UpToDate, they're saying we just don't really know. So there have been, what patients most commonly report is symptoms of, alongside autoimmune disorders, they may present with fatigue, malaise, fibromyalgia. And then there's new studies suggesting that maybe when these implants are removed, patients feel better, but then there's others that aren't really showing any change. So.
Right. And I mean, it's certainly true that certain medications can trigger lichen planus and lichen sclerosis, like checkpoint inhibitors we know that are used to treat cancers. I have a patient who has been on a checkpoint inhibitor and had the development of lichen sclerosis while she was on one. Now, of course, if you're going to choose between lichen sclerosis and treating your cancer, it's kind of a no-brainer, but it still means that some of these drugs can have long-term consequences, and sometimes they don't get better even after going off those drugs. So we know that there are medical things that cause these conditions. It doesn't seem super far-fetched to me that external material could trigger something that causes a problem, but I just think that we don't have enough data.
Yeah, and I think that the takeaway is that these symptoms are real and that these patients are feeling them, but we don't really know what the connection is.
Right. And so, like, if the timing is super suspicious, well, obviously, from a gynecology standpoint, I'm going to treat the patient regardless of whether they have implants. But I guess, did the case report say that she approved when she got the implants out? Did she have them explanted?
I don't know. Well, I
Yeah.
don't think
It's
they
hard.
just treated with topical steroids and they kind of let it be.
Okay. Yeah, it's not like you can make a determination about whether someone's recommended to have these explanted just because of one case study.
Right.
But,
Exactly.
just to decide for themselves, if they feel
And then I think that, again, the problem with a lot of these studies is they're not very well designed and the quality of data is low. The data that's out there has not shown a definitive link between cutaneous connective tissue disease or connective tissue disease more broadly and silicone breast implants. So,
yeah. It is something that I hate these. I mean, having done these studies, it's really hard to do them well, the big database studies, but for rare outcomes. I mean, this is something that if you had a commercial insurance database, and you could track patients who were in the insurance database for a long time, you could look at if they have the surgical code for, if they have the breast implant code, and if they, if their risk of subsequently having a lichen sclerosis or lichen planus diagnostic code. But those studies are so limited because you could have a patient that's going outside their insurance to get all these cosmetic procedures, and you wouldn't know if they, I'm just kind of talking it through myself in terms of my brain always goes to like study design and how would we do that?
yeah. Yeah, I mean, I think here one of these other papers found that while removal of breast implants can reduce symptoms, improvement is independent of whether the capsule is removed totally, partially, en bloc, or not at all. Again, I mean, I don't even know how you interpret that. And that was a study that was published in 2023, and that was a prospective blinded study with 150 patients.
Yeah. I think, I mean, it's interesting. I always ask, obviously, like everyone, seeing a new patient, their surgical history. I am going to keep my eyes and ears out for people who do have a history of breast implants, and just kind of see what I think. Yeah. Interesting thing to follow anyway.
For sure.
Yeah.
Well, what a great episode.
Yes, that concludes another Vulva Talk episode. Hooray, episode 3.
So again, this is Vulva Talk. I am on Instagram, Dr. Cox, DOCTOR.COCKS. I talk about vulvas on there.
I'm Dr. Kylie Moss, DrChailEEMOSS, and Instagram, YouTube, and Reddit.
Send us if you have questions, just like send a DM or comment on a post, and maybe we'll get around to it next time.
Yeah, in April. Very exciting.
All right. Adios.
All right, cool.